All right, folks, let's go ahead and get started. This is our first multimodality imaging conference of the academic year. So, and I thought we'd mix it up a little bit and we'd start out with cardiac MRI as our first topic this year. And so what I'm going to do is talk to you not so much about the clinical applications, but today it's really taking us back to some of the basic principles behind which cardiac MRI works. And so obviously, I think most of you have seen this example here on the left-hand side, which is an MRI scanner. And so you know that it's like a little, people like to refer to it as kind of a donut type machine with a table that pulls in and out that the patients lay down on top of. And a few things, obviously this provides the ability to do non-invasive imaging, requires no ionizing radiation, but we do use high magnetic fields, and I'm going to touch on this more throughout the talk. So careful screening is required before we put anybody into the magnetic field, into the scanner itself, or even just let them go into the room itself. Now, the end result is all of these different images here. And really, I think what this slide tries to show is the power of the CMR technique with the ability to really do a variety of different types of imaging of the heart. And so over the course of this academic year, we're going to actually go through a lot of these different indications and talk about how CMR is utilized to achieve images to help us take care of patients with this variety of different cardiac disorders. But let's go back in time in our time machine here. And so I'm going to ask you guys a question, and part of this is designed to keep you guys awake, because the basic talks are always the most challenging to get through. So the first question is, when was the first MRI exam performed on a human subject? 1969, 1980, or 1977? Why don't we get a raise your hands. If you think it was 1969, raise your hands. Okay, we got about 5, 6 people. How many think it was 1980? Raise your hand. We got a sole person in the back there, Dr. Baig. Okay, and how many think it was 1977? Okay, well, it's only about 5 people. So a lot of people are not responding here. So, but actually the last group is right. It was actually in 1977 when the first MRI exam was performed in humans. And in fact, many years later, in the year 2003, the two men that were really kind of credited with making most of the discoveries that allowed the ability to do MRI imaging received the Nobel Prize in Medicine. So you can see it takes a long time from when you do the initial work until you actually get the prize, many, many years. So for all of you scientists out there, keep plugging away. So these are the two guys right here, Peter Mansfield and Paul Lauterberg. And the first thing they imaged actually was to obtain a single cross-sectional imaging of an image of a finger. And how long do you think it took them to do that? Actually 5 hours. So a long time, and obviously we've advanced quite a bit since then, but I think this is where it all got started. So another question for you guys, for MRI imaging, which is the most important element in the human body? Is it oxygen, is it hydrogen, or is it carbon? How many think it's oxygen? Raise your hand. Okay, nobody. Good. Okay, how many thinks it's hydrogen? Raise your hand. Okay, it looks like almost everybody. How many think it's carbon? Okay, so very good. So the correct answer obviously here is hydrogen, in the sense that most clinical MRI imaging that's done is done based on imaging of hydrogen atoms or protons. But in fact, you can do MR imaging with other atoms as well, but that's typically going to be referred to as MR spectroscopy. And the reason why we like doing hydrogen-based imaging has to do with the fact that if you look at the human body, about 2/3 of it is water. And obviously, what is water? Water is hydrogen atoms. So it allows you to get very high signal. So it's the most efficient atom or most efficient element to do imaging with when it comes to MR. So here's kind of an oversimplification here. But this, if you think of it as kind of the basic principle behind MR imaging, which is really, you've got a body on the left-hand side here, which has a lot of protons or hydrogen atoms within it. And then really it's two things that we're utilizing. It's a magnetic field to create, or it's a magnet to create a magnetic field, and then it's radio waves, that we transmit radio waves and receive radio waves. And that, in its basic sense, is what you utilize to generate MRI imaging. And this principle applies whether we're talking about imaging the brain or imaging the heart or any other organ at all. So obviously this is a little bit of an oversimplification. There's a little bit more complexity to it than this, but in the end, really it boils down to these two basic things right here. Now, so we all know about I think everyone's familiar with the aspect that MRI uses a magnetic field. People may not be as familiar with the aspect of the radio frequency waves. Now, do you know what the reason for the radio frequency pulses are? How many of you think it's to change the shape of the nuclei? Raise your hand. How many think it's to change the spin of atoms within a nuclei? Raise your hand. Okay. And how many think it's to change the composition of molecules? Okay, so we got a pretty good audience here. I think most people got that one right, or at least nobody got it wrong. A lot of people are still either busy eating lunch or sleeping or something. So it is, in fact, to change the spin of the atom. So all of this we're going to try to touch on over the course of this next hour. So again, let me now make it a little bit more complicated than the first diagram or the first schematic I showed you, and talk about the different components that are involved in an MRI system. And though, again, all of these in the end boil down to two basic things, either to generate a magnetic field or alter a magnetic field, or to send in and receive radio frequency waves. And so basically, if you look at that scanner that we saw, that I showed you earlier, within that, what people like to refer to as the donut area, there's actually a variety of things inside of here. So one is there's the main magnet or the main magnetic coils that are there, and that's what gives the bulk of the magnetic field. But in addition to that, there's these things that are called gradient coils, and these are actually in three different directions. They're in the X, Y, and Z direction, and we'll touch on what these do. But in a basic sense, these basically have a function of altering the magnetic field slightly at any given location. So you've got the main magnetic field, and then you've got gradient coils, which cause a slight perturbation in the magnetic field. And then, in addition to that, within the main magnetic, or within the bore of the scanner itself, there's also additional coils that are called radio frequency transmitter coils. And the purpose of these is actually emit radio waves. So just like a radio station does, they have a big tower that emits radio waves. That's what's happening here. And then lastly, there's also receiver coils that receive radio waves. So you have coils that transmit waves, radio waves, and coils that receive radio waves. And so for most cardiac imaging, what we do is we actually put coils, receiver coils, directly on the patient themselves. So obviously, we generally are not doing head-to-body image or head-to-toe imaging, so most patients don't get this many coils put on them. But the idea is really to put the coils on the area that you're interested in imaging that can receive the radio waves. Okay, so let's go back now to the main magnet and the main magnetic field. All right, so this is now a strong, constant magnetic field, and that's really defined by the strength of your MR system. So you can think of that as referred to as B naught. Now, to give you an idea, the terminology that we use to define the strength of a magnetic field is a term called Tesla. And so this is not the car, Tesla, but this is actually a unit of magnetization. And 1 Tesla is equivalent to about 20,000 times the Earth's magnetic field. Now, so what are the typical field strengths that we utilize for clinical MRI imaging? And it's shown here. And again, 1 Tesla really means 10,000 Gauss. Okay? So if we said that the Earth's magnetic field is less than 1 Gauss, and the core of the Earth, the magnetic field, is about 25 Gauss, then in a clinical MRI system, we're using between 15,000 to 30,000 Gauss, which means 1.5 to 3 Tesla. Now, there are higher field strength scanners available. There's now a 7 Tesla scanner that's commercially approved for human use. And then there's lower field strength scanners as well. But the bulk of MRI imaging that's done internationally on humans is really between 1.5 Tesla and 3 Tesla for the magnetic field. Now, the other important thing is that the scanner, or within the scanner itself, we also create a reference coordinate system. So this is basically an X, Y, and Z coordinate system within the scanner itself, and that allows the ability to be able to do tomographic imaging, which means that we're not just picking arbitrary planes, but we can pick sequential planes however we want. So we talked about the main magnetic field. Let's talk a little bit more in detail about the gradient coils, right? Because remember I said that there were really 3 or 4 basic components to an MRI system. The main magnetic field, the gradient coils, and then the transmit and receiver radio frequency coils. So the gradient coils exist in such a way that they can cause a local alteration to the main magnetic field in any given direction. So there's a gradient coil that sits in the x-axis that affects the magnetic field in the x direction, one in the y direction, and one in the z direction. And let me skip forward here. What it does then is by altering the local magnetic field, one second, it will then cause protons to align and spin at a slightly different frequency. And so let's go back here for a second. And so what happens to protons, to hydrogen atoms, when they're faced with a magnetic field? Well, they will start to spin around. And they'll spin around in such a way that they line up in the direction of the magnetic field, and then they spin around in a direction that's transverse to the magnetic field that you've lined up. So let's get forward here. And this is basically if we have no magnetic field, you've got protons that are spinning around in all different directions. Some are upright, some are down. And the net, if we summate all of these together, is 0. Now, what happens is once I apply a magnetic field, an external magnetic field, some of these protons start to line up in the direction of the magnetic field. Now, there's still going to be some that are going to be in the opposite direction or some that are going to be in all different directions. But the result of it is that the stronger the magnetic field, the more protons will line up in the direction of the magnetic field. But again, this is on the order of maybe 1 in 1,000 more that are lined upright versus down. And the stronger the magnetic field is, the more number of protons that you'll have that will line upright. And the other aspect to the magnetic field, in addition to lining up the protons in a certain direction, it also causes them to spin at a certain frequency that's based on whatever the magnetic field is. And so there's an equation that's called the Larmor equation. And for those of you that do MRI, this is one that you need to have a good understanding of. And it basically just says that the frequency or with which the protons spin around at, what's called the precession frequency, is actually predictable. And it's basically based on something called a Gear magnetic ratio. This is different for each individual nuclei or each individual tissue. But in essence, for hydrogen atoms, for protons, this Gear magnetic ratio is 42 megahertz per Tesla. And then if you take that and you multiply that by the local magnetic field, that then determines what the strength of the protons, or what the precession frequency of the protons are. So at 1.5 Tesla, that means that the protons will be spinning around at 64 megahertz. And at 3 Tesla, they'll be spinning around twice as fast at 128 megahertz. Now, what happens then when a patient goes inside the bore of the scanner? Then the patient's tissue begins to spin around at that frequency based on what the magnetic field is. Now, let me, another important thing to keep in mind is that the strength or the size of the magnetic field will determine the maximum signal intensity that you achieve, because that's the number of protons that you're able to affect. All right, so let's kind of put this all together and say one other thing that we will do is we're going to actually apply now what's called a radio frequency pulse. And what's the purpose of a radio frequency pulse? It's actually to cause protons to go from that resting state, which is upright, to actually be tipped down into the transverse plane. And however strong of a radio frequency pulse you apply determines how far the protons will tip down, whether you tip them down just 10 degrees, 45 degrees, or 90 degrees, or even further, 180 degrees. So I've got a little movie here, which actually I think really shows this nicely. So let's skip forward a few slides. Here we go. Let's see if this plays. Whoops, not that one. Okay, let's see. Let me come up here. Okay, so here we go. So you notice what happens is there was a radio frequency pulse that was applied. And so here's the protons right now. They're all upright. And watch what happens is as you apply this radio frequency pulse, which is that purple wave right there, it shifts the protons down now into the transverse plane. So this is when you apply 90-degree pulse, you go from the vector being upright to being horizontal. But notice what also happens. Let me go back a little bit here. Is that they continue to spin around, but now instead of spinning around upright, they're spinning around in the transverse plane. And then there's one other aspect that's going to happen, which is over time, these protons will slowly get out of phase. And what that means really is that they're not all marching together. So you can just think of it like on a racetrack. And you start out, all the cars are at the starting line, and they're all going around together. But then over time, after a few laps, they start to spread apart. Some start to go faster and some start to go slower. And the net result of that is the net magnetization that you get back is going to gradually dissipate over time. So there's things that we can do to try to cause them all to come back together. And these are all things that we'll touch on in later lectures, or for those of you that are interested in some of the advanced MR physics lectures that we'll have. But let me get back now to the basic principle here is when we tip these protons down, in addition to them becoming incoherent with each other, they also will tend to go back into the native resting state, which again is upright. And that's a principle called MR relaxation. So the idea is that if I tip everything down to 0 degrees or to 0 longitudinal magnetization, but 100% in the transverse plane, over time that magnetic field will pull them all back up to the resting state that they were in. So that's the normal low energy state that the protons will try to eventually return back to. So, so there's two orders of things that are going on. One is in the longitudinal or the upright state, you essentially have recovery or regaining of the magnetization as these protons go back upright. And then in the transverse plane, as they're all spinning around together and they start to become separated from each other, you actually have a dispersion of magnetization within the transverse imaging plane. So really there's two principles. One, which is the longitudinal recovery or regaining, is referred to as T1. And then the T2 star is a rate at which the protons begin to disperse within the transverse or the horizontal magnetization plane. Now a couple of things to keep in mind. Both of these phenomena are occurring at the same time. And in general, T1 is a slower phenomenon. So the T1 recovery or regain of magnetization is slower than the T2 star decay or loss of magnetization. Okay, so let's kind of probe a little bit more into T1 relaxation. And this is a schematic that's just showing you that, which is at any given time, when you tip everything down into the transverse plane, what will happen is gradually you'll start to get regrowth within the horizontal imaging plane. So you start at the longitudinal plane. You start at 0, and it gradually gets higher and higher and higher. And we could actually plot this out. So we could plot out what happens when we tip everything down to 0 longitudinal magnetization, and then what happens over time. And obviously what happens over time is that you have gradual regrowth of your magnetization, and until eventually it'll get back to 100%. But the speed with which it regrows can actually be calculated, and the T1 time constant is something that's chosen as the time it takes to regain to 63% of your original magnetization. So if you tip it down to 0, how long does it take for it to get back 63% of that magnetization? That's called the T1 time constant. Okay. Now, and the reason for this is basically that there's an energy release from the protons as it returns back to the equilibrium state, which again is upright. And then this is related to the size and tumbling rate of any given molecule. So the T1 time is tissue specific. So certain tissue has a specific T1 time. So for T1 time, if you look at it, and this is a graph showing the rate at which recovery occurs for different tissues, and you'll notice the fastest recovery, the shortest time to get to 63% magnetization is for fat. So fat has really the shortest or the fastest T1 recovery time. Normal myocardium is somewhere in the middle. And then water, which obviously has the slowest T1 recovery time. As you can see here in this schematic, the amount of time it takes for water to regrow back to 63% is very long, on the order of about a couple of seconds. And then there's one other principle, and we'll touch on this in later lectures, which is that if we look at the T1 recovery time for myocardium, it differs depending, again, on whether I've given contrast or not. The basic principle of gadolinium contrast is that it causes a shortening of T1 recovery time. So if I look at the recovery curve for myocardium, which is shown here, without contrast, once I give contrast and an area that holds on to contrast like an infarct, will actually have a faster rate of T1 recovery as a result. So let's keep going here. So the other aspect we touched on, is the aspect that, the protons will gradually start to go out of phase or separate from each other within the transverse or horizontal imaging plane. And then we can actually calculate how far off they are from each other by using a principle called the phase angle. And so the idea is that spins that are at similar phase angles will all be in phase. Spins that are at different phase angles from each other will all be out of phase with each other. Okay, so again, I showed you in that block simulation that once you tip everything down, over time, the protons gradually start to get out of phase with each other. And so that's really a principle called dephasing. So the natural tendency is over time, protons are going to start to get dephased from each other. Now there's things that can accelerate the rate of dephasing, and we can actually utilize those principles to do things like determine the amount of iron content within the myocardium or within a given tissue. But again, it goes back to the same basic principle. And I'll show you again on that block simulation the dephasing aspect. Let me see if I can get this thing to... All right, so things get tipped down, and then they're all spinning around together, but then gradually, notice they start to get more and more apart from each other, so they're starting to get out of phase with each other. So they're not all synchronized in their motion, but actually they're desynchronized. Now, what that rapid thing right there just showed you was what happens now if I apply another radio frequency pulse here, which causes then a 180-degree flip. So it just flips everything over completely to the opposite direction. And so you can think of it the same way as if you're on a racetrack and a bunch of cars are racing around, and all of a sudden you say, okay, now reverse. Well, as they reverse, they'll actually start to all come back together again, right? Because the ones that were faster are going to be further out than the ones that were slower, but then as they reverse, they all start to converge back together again. And this actually is the basic principle behind which we do things like spin echo imaging. Okay, so the causes of this dephasing are actually twofold. There's things that are due to what's called spin-spin interaction. These are exponential and they're irreversible. And this leads to what's called T2 relaxation. And then there's also things that are due to local field inhomogeneities. And this basically is something that's reversible. And that leads to what's called T2 star relaxation. Okay, so let's keep going. So here's an example now, again, of the T2 decay that occurs over time. So whereas with T1 you get recovery, with T2 you actually get a gradual reduction in the net magnetization vector until the point at which it gets to 0, where everything is completely out of phase with each other. So if you look at it from a far distance, nothing is lumped together. And the T2 time constant is defined as the amount of time that it takes to go from your 100% magnetization once you tipped everything over into the transverse plane until you lose 32%, or until you get to 37% of the resting magnetization. So basically, T1 is a regrowth of 63%. T2 is a loss of 63% such that you're down to 37% of the peak magnetization. That's your T2 time. And then T2 time also is tissue specific. And to some extent, it's a little bit different in that water, which had very long T1 time, also has very long T2 time. So you can see here the amount of time that it takes for water to decay away down to 37% is very, very long versus the amount of time that it takes, let's say, for myocardium or fat to have T2 decay occur. So if you think about it, T2 relaxation really, if you think about from the speed at which it occurs, water is going to be the one that has the slowest T2 decay, then muscle or myocardium, and then lipids are going to have what we call intermediate T2 decay. So we can actually choose now the type of imaging technique that we want to utilize, or the imaging pulse sequence that we want to utilize, such that it can weight the image intensity based either on the T1 properties of the tissue or based on the T2 properties of the tissue. So I'm showing you an example here of a patient who has a large pericardial cyst. Now that's going to be mainly composed of water-based substances, right? So now if I do a T1 weighted acquisition, notice then that water, which has very slow T1 recovery, actually is going to appear gray or dark. Whereas if we look at fat, which again we talked about has very fast T1 recovery, is actually going to appear bright. Now I could image that same patient, but this time now, if I image it using a T2 weighted pulse sequence, a T2 weighted technique, this now will encode high signal for things that have long T2 decay times, and therefore you'll see here in this example that fluid within that pericardial cyst now actually appears very bright. So the key is if I show you an MR image and say, okay, what is this tissue that we're looking at here, you really need to know what type of imaging sequence it is, because just simply knowing it's bright or dark doesn't really help you unless you know what kind of imaging sequence was utilized to generate that image. Okay, so next now is let's talk about how we're going to actually use this now to actually make an MR image. So there's a couple of steps that are going to be involved in this, and really, or 3 steps I should say. The first step is what's called a slice selection. So we pick the slice that we want to image. Next, then there's going to be a thing called the phase encode step, and then last, something called the frequency encode step. So the beauty of MR, I think, is the fact that you can just arbitrarily select whichever slice it is that you want to image. So how is it that you're able to do that? And again, this goes back now to the principle of these gradient coils that we talked about earlier. And the net effect of a gradient coil is that it causes an alteration to the magnetic field. So if I show you, here's a patient who's inside an MRI scanner. And let's say this is at a 1.5 Tesla scanner. Well, once I apply a gradient coil that's in the z-axis, which is in the head to foot direction, the net effect of that will be as follows. There'll be a slightly stronger magnetic field in one direction and a slightly weaker magnetic field in the other direction by applying a gradient in this axis. So as a result, if this is what my isocenter, what I call the center of the magnetic field, then anything to the right-hand side, and so again, the isocenter, let's say, is 1.5 Tesla. That means this is 1.5 Tesla magnetic field here. As I go further and further away from this, the magnetic field locally is going to get higher and higher and higher. So within this patient, the head may be at a magnetic field of 1.51, whereas the foot will be at a slightly lower magnetic field, and let's say it's at a magnetic field of 1.49. So the magnitude of changes we're talking about are really very, very small, but they're enough that allows us to be able to exploit it to pick the slice that we want to image. So what's kind of the impact of having this magnetic field be slightly different at the head versus at the foot versus at the center of the body, right? The impact is that if you go back to that Larmor equation, which says that basically protons spin at a certain frequency times the local magnetic field, what it means is that the protons here will be spinning at 64 megahertz. What about the protons that are up here in the head? What will be the frequency of those protons? Will it be 64 megahertz, or a little bit more, or a little bit less? It'll be a little bit more, right? Because the magnetic field here is a little bit more than 1.5 Tesla. And the protons that are down here will be spinning at a little bit less. So, again, the magnitude of difference is very little, but for arbitrary purposes, let's say this is 64 megahertz here, here it's 65 megahertz, and down here it's 63 megahertz. Now, if I want to select a slice to image, and let's say I want to image the brain, then I would say, okay, let's send in a radio frequency wave at 65 megahertz. Because again, remember, when you transmit radio waves, only things that are spinning at the same frequency will be able to actually absorb those radio waves. So the rest of the body, even though I sent in radio waves at 65 megahertz, the rest of the body doesn't see it. So only the tissue in the area that I'm interested in imaging actually sees these radio waves, and only those protons get excited. So that's really the basic principle behind the slice selection. Now, so it's two things that are involved in doing this, so this gets a little bit more complicated. Obviously, it's the bandwidth or the group of RF frequencies that I'm going to transmit, and it's based on the steepness or the strength of the gradient, right? But in the end, from a simple standpoint, you can basically say, if I want to do brain imaging, in this arbitrary example, I would send in RF waves at 65 hertz. If I want to image the heart, I would send them in at 64 megahertz. And if I want to image the feet, I would send them in at 63 megahertz. And by doing that, I only get signal back, as I'm going to show you how we actually generate the image, from that specific area that I'm interested in imaging. So I pick now a location that I want to image. And I can pick a slab, which means I could pick the whole brain, or I could pick a very thin slice. And the way that the radio frequency waves are transmitted in will determine how thick of a slice I want to excite as well. So it's based on the gradient that I apply, and the range of frequencies that I transmit in will determine if I want to do a 5 millimeter thick slice or a 10 millimeter thick slice or whatever you want to be able to do. So the nice thing is all of these things are simple parameters that can be changed on the scanner at the time of imaging. Okay, so the next step now is what's called the phase encode step. So this is step 2 in generating our image. So the first step was basically exciting a specific slice that I want to image, and I'm doing it in such a way that I only excite that slice and not anything else. So I'm only getting signal back from the specific slice I'm interested in imaging. Now the next two are a little bit more complicated. So the phase encode step basically is now a second gradient that I apply, but this now is applied in a different direction. So this will be applied in, let's say, the y-axis, and this would allow me to encode information within the y-axis of the slice that I'm interested in imaging. And again, this has to do with the fact that if I cause an alteration in the magnetic field now in the y-axis, the protons in the y-axis will now begin to spin at slightly different frequencies depending upon how far away they are from each other. And then what I will also do now, in addition to applying this phase encode gradient, is there's a third gradient that we can apply, which is in a third axis, which we call the x-axis, which will be utilized to do what we call frequency encoding. So essentially, the initial slice selection gradient to pick the slice I want to image, and then once I do that, I need to now get an x and a y axis within my single image, and that's using two gradients, a phase encode gradient and a frequency encode gradient. And let me skip past this here. And let's talk a little bit about the frequency encode gradient. So the frequency encode gradient is actually a gradient that is applied for differing durations of time. So I'll do this experiment or this sampling multiple different times by applying a slightly different gradient each time. And each time when I apply a gradient, it causes protons that are further away versus those that are closer to spin slightly differently. So that they start to get out of phase with each other, right? But there's a pattern or method by which they get out of phase. And you'll notice if the gradient here was lower, the net phase shift from the resting, which is all upright, to here is very little. As the gradient gets higher and higher, as these protons spin around faster as I go further away, the net phase shift becomes larger and larger. Okay, and then we'll actually do this still by applying a series of repeated gradient encode steps with faster and faster gradients. And that allows you to actually sample what the differences are between when you apply a weak gradient versus a stronger gradient versus a stronger gradient. And then every time, whenever we apply radio frequency pulse, we essentially then will get a radio frequency pulse that will come back. And that's what's called the MR signal. So that's the receiver coils that we typically put on the patient's body that will now receive the signal. As these protons go back to their resting state, they actually emit a signal back. And we can actually capture the different radio frequency waves that are sent back. And then the next step is a complicated step, but essentially it takes all of these different radio frequency waves that come back with each separate phase encode step that we do, and it then results in a series of lines of what we call K-space, which then you can deconvolute, or you can do what's called a 2D Fourier transformation to actually go from information about phase and frequency to actually be able to generate an image itself. So there's a lot of steps involved here, and so this is an oversimplification, but essentially if you take the phase and frequency encode information that you receive back with each phase encode step, you can actually then do what's called a Fourier transformation, and from that generate an image itself. All right? So I think the one basic principle to keep in mind is that with MR, each line of data that we acquire somehow contributes to the image. So I could actually reconstruct the image with only the top half of K-space, and it would not give me just the top half of the image. It'll still give me an image. It's just that the image properties may be altered somewhat, so the resolution of the image or the signal to noise of the image or the image contrast may not be the same. But the basic principle is that every single line of data that you acquire doesn't just acquire part of the image, but somehow contributes to some aspect of the image. But you can generate an image with just the center of K-space, with just the peripheral lines of K-space, with just the top half, the bottom half, whatever you want. All right? So it's different than, and as a result, when I do this in multiple steps to get all of my data, if I have missing data, if I have an arrhythmia that occurs when I'm acquiring some of my data, or the patient is breathing when I acquire some of my data, it doesn't cause me to lose part of my image, but it causes an artifact on the image. And we'll go through in later talks what these artifacts look like. Okay, so this obviously is one of the most challenging lectures, I think, to give and for people to receive. And so I want you to just sit back for a second, and I know it can be stressful. And again, think about it. The ultimate goal is essentially to use all of these basic principles of MR imaging to then be able to do it in a specific manner by which we can actually generate images that give us a variety of different pieces of information, whether it's perfusion, whether it's tissue characterization looking at RV dysplasia or myocardial infarction, whether we want to look for pericardial diseases, look at aortic disease, coronary, valve disease, cardiac masses. All of these can be done with a simple CMR scan. Okay, so one last piece of information, one more thing I want to make sure you guys, we don't leave without discussing. Maybe this is dating me, I guess. You guys probably don't remember Columbo. Okay, maybe John back there, you remember, right?
Columbo was awesome.
Yeah. So
he smoked a cigar.
that's right. So here's the basic thing I want you guys to leave with. Okay, it's a powerful magnet, and it can be very dangerous. All right. Here's an example of somebody who wasn't paying attention and said, "Let me wheel this cart in." And look what happens. And the reason is, what happens to a magnet? A magnet, if you take metallic objects that are what's called ferromagnetic, which means they attract to a magnetic field, it will pull them. And the thing is, the strength of the magnetic field gets stronger and stronger the closer you get to the magnetic field. So it actually pulls it at an accelerating rate, so it becomes a projectile. So there's cases of death that have occurred. So you need to always recognize two things. The magnet is always on. So at the end of the day, everybody's gone, the lights are turned out, the magnetic field is still there. The magnetic field is still on. It never is turned off. So you need to, the same as whether a patient's in the room or the lights are turned out and it looks like everyone's gone for the day, you need to be aware of the strength of the magnetic field. And so as a result, a few things. All personnel must be trained and screened to work in an MRI environment. And that means not just patients, but also personnel. If you're working in an MRI environment, you have to be screened to make sure you don't have any metallic objects, which could be a problem. And therefore, we want to use screening forms on every single patient that comes through the lab. And this is very, very serious. Sometimes it's one of those things you can kind of take it, okay, checkbox, checkbox. But this is very serious because it's cases where people were lax in doing the screening and put the patient into the scanner where disasters can happen. So a couple other things to keep in mind. is, for patients that have any kind of occupational exposure to metal, so if they've done any welding or grinding or anything like that, where they could have little metallic chips in their eyes, those are examples of cases where we want to make sure we get an x-ray, because certainly you don't want a small little metallic object that's in their eyes to move and cause them to go blind. So, safety is one of the key things that you have to be aware of. And we also have kind of a nomenclature by which we define objects. So they're defined either as MRI safe, MRI unsafe, or what's called MRI conditional, which means conditionally MRI safe. Now, it's important to kind of recognize the difference between these because people have a tendency to kind of say, is it MRI safe or unsafe? Very few objects are actually MRI safe. And MRI safe really means something that poses no known hazards within any given MRI environment. So what would be something like that, like a petri dish, a plastic petri dish? So anything that has metallic components to it can never really be MRI safe. Okay, it could be MRI conditional, and what that means is that has no known hazards in a specified MRI imaging environment with specified conditions of use. All right. So when we talk about pacemakers that are MRI safe, they're not really MRI safe. They're labeled as MRI conditional. Pacemakers or defibrillators or any device that's put into a patient. And obviously MRI unsafe is something that's known to be hazardous that you don't want to do. So, and the reason for this MRI conditional nomenclature, because in the past the FDA used to use MRI safe and unsafe, is because we don't know all the possible scenarios when you're talking about within the strength of the magnetic field, the location of the specific device, what the type of imaging sequence that you're utilizing, if there's other devices the patient may have as well that may interact. So there's a lot of different interactions that can occur that there's no way that you can possibly know of all of these possible interactions that can occur. And that's why they use the terminology conditional to say at least in the set of conditions that we've tested it in, it appears to be safe. And so I think when it comes to scanning a patient who has a device, really need to look it up for each individual device. So you can't apply a blanket statement that all stents are safe, all pacemakers are safe. You really need to look it up for each individual device. And so that's why there's a nice website you can go to called MRIsafety.com, and has an extensive list there of all FDA-approved devices, and it will tell you what their labeling is, whether it's labeled as MRI safe or MRI conditional. And if it's labeled as MRI conditional, as is shown in this example, is it at 1.5 Tesla and 3 Tesla, or has it only been tested at 1.5 Tesla, or has it been shown to be tested at 3 Tesla? So you need to really know what the labeling instructions are for that device before you put a patient into the scanner. So any patient with a device, ideally we want to have a card to know exactly what kind of device, the make and model they had. Look it up, see if what are the conditions in which it can be safely done, and then obviously try to mimic those conditions for that patient. Okay, so let me pause here. I wanted to leave some time for questions because I know this is kind of a mind-boggling topic that can cause your head to spin around. So any questions or comments on what we talked about so far? Or you're just spinning around? Okay, and again, the first basic physics talk is always the toughest. The rest of the series for the year is going to be much more clinically applicable topics. But we really need to know your basic methodology to then be able to apply it to clinical scenarios. Okay? Thank you for your attention.